And welcome to the Dr. Bob Show. Childhood asthma is a huge problem. It causes cough and wheeze and shortness of breath. It is different than asthma in adult life, and we have to treat it differently. We have to be able to recognize when somebody has cough, wheeze, shortness of breath, tightness in the chest, waking up in the middle of the night with a cough, going out and playing in the playground, and suddenly get a tightness and a wheezing in the chest that is so easily treated, but if we overlook it, can go on and cause problems later on. My guest is Dr. Karthik Krishnan. Dr. Krishnan is a board-certified pediatric allergist, and he'll be teaching us about childhood pediatric asthma and what we need to do for it. Hello, I'm Dr. Robert Overholt. I'll be your host for the next 30 minutes on the Dr. Bob Show. And I'll be learning too about pediatric asthma and how important it is for you and your family. A lot of information for you. You'll want to stay tuned. We're talking with Dr. Karthik Krishnan, board-certified pediatric allergist. We're going to be talking about a special type of allergies in childhood, bronchial asthma. A lot of information with it. Karthik, welcome to Dr. Bob Show.
Thank you for having me, Dr. Bob.
So what is asthma?
Okay, so asthma is a problem with the airways in the lungs, and there's two parts to it. There's obstruction, which is caused by inflammation and swelling, and also you can have twitchy airways. That's where you have bronchospasms.
Are both of them treated?
Yes, they can be easily treated.
Both of them have different set of symptoms?
Yes, yes. So the common symptoms that we see with asthma are going to be coughing, wheezing, shortness of breath. You can have chest tightness, or some people will call it air hunger. They just have trouble getting air into their lungs.
How bad is it?
So it can be pretty bad. It can cause a lot of impairment with activity. It can cause impairment with sleep at night. Some children will stay up at night coughing and interfere with their sleep.
And mom and dad sleep too.
Yes, that's right.
With the child in the next room. Is it different than adult asthma in general?
Yes, it's a little bit different. The physiology is a little bit different than we see in adults.
So let's go to the physiology.
Yeah.
You said there's some cough and wheeze. So what makes the cough and what makes the wheeze and what makes the shortness of breath? Those
yeah,
three
so
things.
a couple important things. One was we're not born with asthma. It develops over time. So some children are genetically predisposed to have asthma. So if there's a family history, particularly on the mother's side of the family, they're more prone to get asthma. Also, if they have allergies like nose allergies and they test positive to certain environmental allergens.
How does the allergy cause lung problems?
Yeah, so what happens is there's inflammation or swelling in the airways, and that traps or hold on to air.
Now,
and
when you say inflammation,
Yeah.
excuse me for interrupting, but I immediately think of infection, like we've got a bronchitis or something.
Yeah.
Is it a different kind of inflammation?
Yes, it's a different kind of inflammation from infection inflammation. There's usually not fever associated with, you're not coughing up colored sputum. This is more just a dry, persistent, hacky type cough.
Does it cause problems in the airway, the inflammation?
Yes, so what happens is the airways get swollen, you get more the muscles in the airways get real large, and so it narrows the airways. So the air gets trapped in there and you have trouble getting it out. So you really have to squeeze and work hard to get the air out, and so you have to cough to help get that air out. You can also when you wheeze, that helps that's a sign that the air's trapped in there and it's having trouble coming out.
Is it usually a problem as you're trying to breathe in or as you're trying to breathe out?
It's primarily a problem of trying to get the air out, because with asthma it's an obstruction and air is trapped in the airways.
So every time really you take a breath, you just trap a little bit more and a little bit more and a little bit more.
Correct.
Does the chest get swollen?
It can.
And so the treatment is to unswell it?
Correct, yes.
So we've got the inflammation. Where does twitchiness of the airway come in?
Yeah, there's these they're called smooth muscles, and they squeeze and they relax and they squeeze and relax. And if you have asthma, you have a lot more squeezing and relaxing of these airways. So they're twitchy or they're very reactive.
So what triggers make the airway reactive?
Yeah, so there can be a lot of triggers for asthma. So we kind of keep it pretty simple. There's very specific type triggers, and then there's non-specific triggers. So some simple non-specific triggers are going to be like secondhand smoke or cigarette smoke itself.
So
Correct.
if you're smelling somebody else's cigarette smoke.
Correct.
So secondhand smoke,
Yeah,
somebody in
yeah.
the car that
Correct.
smokes around a child,
Yeah.
does that harm the child's airway?
It can, yes.
So don't smoke in that car.
That's right. No smoking. Air pollution can do it. Weather changes can do it. Infections, specifically viral type infections. The one that's notorious in children that's associated with asthma is called rhinovirus. That's a very pathogenic virus that can lead to asthma later in life.
So if somebody gets a rhinovirus, what does it do to the lungs as far as how quick does it make them wheeze, or does it sit there and cause trouble 10 years later?
It causes acute symptoms, but the damage it can cause can affect them later on in life.
And the symptoms they get are just worsening of the cough, wheeze, short breath, tight chest.
Correct.
So do you treat the allergy? How do you diagnose the allergy? Let's talk about diagnosis.
Yeah, so you start with history, and we're asking about how often they have symptoms, when they have symptoms, what their triggers are, and then we can do a physical exam, and we want to listen to the lungs if we can hear any wheezing.
What does wheezing sound like?
So it's like a little whistle. It's just a
And as they're breathing out, they're trying to get
Correct.
that trapped air out,
Yeah.
and you can hear the whistling noises. Can the patient hear that? What symptoms do they have when they're wheezing like that?
So a lot of times you can't hear wheezing, but if there's a lot of air trapping, you can have what they call audible wheezing. So when the patient's sitting there and you have them exhale, you can hear them go,
Yeah, you can hear that.
that last little bit, they're just squeaking it out there.
So it's late expiratory when you're
Correct.
breathing out, wheezing.
Correct.
How do you pick that up? What kind of testing?
Yeah, so after you can go by listening, but the best test to diagnose asthma is a lung function test called spirometry. And what it is, it's where you blow out as much air as you can over 6 seconds. And so we're able to measure how much air they can blow out over this time.
So the computer gives you a readout on every millisecond, and it will tell you
Correct.
by a pattern. Do you have to show improvement, or do you just have to show badness?
Yeah, so what we're looking for a specific type pattern. What we're commonly looking for is an obstructive type pattern. And so we look for an obstructive pattern, and then one common thing we do is we give them a breathing treatment with a medicine called albuterol.
After the initial one?
Correct. So we
So
do
you got
the
a
initial.
pre-albuterol and a post-albuterol.
So then we check after we give them an albuterol treatment. We wait 15 to 20 minutes after the treatment is completed, and then we repeat that lung function test, the spirometry.
Shows improvement?
Correct. We're looking for changes, and one specific marker we're looking for is called the FEV1. That's called the forced expiratory volume in 1 second.
So as you blow out 1 second,
Yeah.
it gives you a value.
Yeah, that's how much air you can blast out in the first second. So what we're trying to look for is a change in that. If there's an increase of 12% or 200 mLs in that FEV1, then that's
mLs, milliliters.
milliliters, correct, milliliters. So that's diagnostic for asthma. You can make a firm diagnosis.
When you see that greater than 12% improvement, then you say, we've got to do something to help this patient. What if you don't do something? What happens over the next 2 years, 3 years, 4 years?
Yeah, there's a process called remodeling, and that's where there's ongoing chronic damage to the airways. They get real stiff and they can get real hard, and so it progresses to a severe state.
So you want to find it early, you want to treat it early, you want to
Correct.
get them to. Can you get it back to almost normal?
Yes, you can.
Yeah, and that's the goal that we have. We're going to be talking a little bit more about the development of a treatment pattern, because there's a lot that goes on with the treatment of somebody that has had spirometry at a pediatric age and room for improvement. A lot of information, very, very exciting, very, very defined. It's something that we can define with tests, and we can get the patient better where they won't have trouble later on. You want to stay tuned. We're talking with Dr. Karthik Krishnan, board-certified pediatric childhood allergist. We're talking about pediatric asthma. We've talked about what is it. It's inflammation that causes swelling, narrowing of the airway. So when we breathe out, you hear the whistling noises, but also twitchy. It's real easy to get the airway to go into spasm. We can make the diagnosis with spirometry, a very simple thing where you just blow, 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 and it'll give you a measurement. And then we see if we improve after giving medicines when the diagnosis is made. Is that a good summary?
It's perfect.
So, so let's talk about the treatment. What goes on with the treatment of asthma?
Yeah, so we have some great options. Some of the simplest things to start with is just identifying triggers and avoiding these triggers.
So there are triggers that make the asthma occur.
Correct, right. So that's a simple thing. And then the next option we have are medications. And so we have some great medication options to help with asthma. So there's two types. There's as needed, so just kind of quick relief, and a common one for that's called albuterol. And then we have preventative, everyday or controller type inhalers. So those are ones you use every day to prevent problems, to keep the symptoms under much better control.
So your spirometry guides you as to whether they need the controller or the reliever.
Correct.
In general.
Correct.
Everybody's different.
Yep. So we rely on the history as well as the spirometry. We kind of use both of those to decide which one works best for the patient.
Give me some examples on the history.
Yeah, so if they just cough and wheeze occasionally, just maybe when they're sick, or when they go visit grandma and she has a cat and the cat causes them to
the
cough.
Cat of doom, we call it.
So in those cases, we could just use something as needed. Now, if it's somebody, if it's Buster who's playing lacrosse and every time he's out there running around, he's winded and gassed and he's coughing and just having trouble.
So exercise is a trigger.
Correct.
How do you handle that?
Yeah, so we have a couple options we can do. We can have them use the fast-acting rescue inhaler before exercise.
Before? How long before?
Typically 10 to 15 minutes before. Or we can put him on a preventative or everyday inhaler. This will get his symptoms under much better control, so it won't interfere with his activity.
So show me how to use a reliever.
Yes.
Which one? You've got a whole bunch of things lined up here.
Yeah. So these props, the important thing, what I try to focus on with my patients is trying to match the right inhaler for them. There's two types of devices. We have breath actuated, and we have propellant, or ones that you have to mash down or push down and the medicine comes out.
So one shoots it out.
Correct.
The other one, in order to get it out, you have to trigger by breathing in.
Correct. So depending on their age and how coordinated they are, we have to kind of match up one that works best for them. So the breath actuated ones are actually really easy to use. You just open it up, you'll hear a click, and you'll put your mouth on the mouthpiece and you just suck it in. So you'll just go. So pretty easy.
It's important to start off with no air in the lungs. So you blow it out first, put it there, and you have to get that pop, that trigger.
Yes.
And then you have to have them slow it down or suck it down fast.
So with the breath actuated, you want to go pretty fast. I tell them to be pretty firm and aggressive with the inhale. Now with the propellant ones, these are ones that you mash down and the medicine comes out.
Let me see the propellant one. So you have to shake it up.
Correct.
And you can see, that's pretty cool.
Yeah.
So you have to time it right.
Correct.
Can't spray it back there. You got to spray it into your mouth.
So in children, to prevent having a lot of coordination and timing, we use devices called a spacer, okay? And there's a couple types of spacers. This one is just a plain spacer. This is a spacer with a mask. So in children who are infants, toddlers, 4, 5, 6, you want to use a mask. And what you do, it's real simple to use. You plug the inhaler into here, you shake it up, you mash it down. The medicine will wait in here. So you don't have to rush, you just take your time. This goes over the nose, this goes under the chin, and they'll take 5 or 6 breathing cycles. So what I'll say is inhale, exhale, that's 1, inhale, exhale, that's 2, and they'll do that 5 or 6 times. If they have to do a second puff, we have them wait 1 minute because this canister needs time to re-aerosolize. So we wait a minute and then we repeat the whole process.
So that's really innovative. It really takes away the problem of not getting the medicine down your lungs. You're pretty much going to have to get it down there.
Correct.
That's great.
So for prescribing the medicine, 1, we want to make sure they take it, but 2, more importantly, we want to make sure they're taking it properly so it's getting into the airways where it's going to make a difference.
So people can take it improperly. I saw a picture one time where somebody shook it up, blew out, and sprayed it in their ear. It didn't do much good.
Well there,
So other devices?
Yeah, so this is another breath actuated device. So this is one it's real simple to use. Same idea, you open it up and then you put your mouth.
Click. You have to wait for it to click.
So you have to wait for it to click. There's a little blister pack inside, and when you open the cap, it pops open that blister pack. And so the medicine is in a powder form. And so you'll put your mouth on the mouthpiece, and once, like you said, you blow out your air first, and so you'll go. Hold your breath for 3 to 4 seconds, close the cap, and you're done. Okay?
That's
so really easy, easy.
And, that's an advance in medicine where it make it easier and easier to take the medicine.
Yes.
So we've gone through the spacers. What kind of medicines do you put in them? Controllers or relievers?
So for the spacers, you can use both. You can use you can put a fast-acting inhaler with it, or you can put a preventative or controller inhaler with it.
So let's take the albuterol. You mentioned that. Tell me about its action. How long does it take? About 6 hours to work, or?
Yeah, so albuterol will work really quickly. It will work within 15 to 20 minutes.
So when you use it, you expect to get results.
Yes, quick acting, quick relief.
How long does it last?
So it can last anywhere from 4 to 6 hours. It can stay in your system.
So what if you take it and 30 minutes later you're still wheezing? Can you take it again?
You can take it again, but we don't want you to do that on a regular basis. And if that's the case, if that's happening, you're not controlled, you need to call your provider to talk to him about obtaining better control of your symptoms.
Yeah, and that's very, very important. Sometimes we're considerate of the provider. We don't want to call them. We don't want them to think we're in trouble because maybe we forgot to take the dose yesterday. But it's important to call the doctor if you need to.
Yeah. And another thing we commonly do, we provide an asthma action plan. This is kind of a roadmap to help them. So if they're having trouble, they have specific instructions on what they can do to relieve their symptoms.
So it'll tell you to use an extra puff or what to do or when to call or when to go to the emergency room. It's sort of a recipe for getting better.
Yeah.
Most people respond to that treatment?
Yeah, medicines are a great option. Most people will respond. Now, if they don't, we have some other options that we can pursue. One of them is allergy shots or immunotherapy.
We're going to talk about that when we come back. So right now we've got medications that should respond, but if you're having too much problem, we may have to do some other things.
Correct.
Can't wait to hear how good the shots are, and what newer medicines called biologics.
Correct.
So a lot of information. You'll want to stay tuned. We're talking with Dr. Karthik Krishnan, board-certified pediatric allergist, and we've talked about a disease where you have cough, wheezing, short of breath, very, very frightening, and yet treatment we can use before a trigger occurs or after an attack occurs or in the middle of the night if you need extra help. So we really get in a treatment program that makes the person live a pretty normal life, but they have to have medicines?
Yes, yes.
Frequently, is it gratifying when you take somebody that's having a lot of trouble and all of a sudden they're able to perform?
Yes, it is.
Can they play sports?
Yes.
Run track?
Yes.
Can they run the mile?
Yes, no restrictions.
No restrictions at all. That's fantastic, and it must be that which brings a lot of joy.
Yes, yes.
So let's continue on the treatment of what we're going to do. We talked about allergy shots. Are they worth it in a child who has allergies and is on good medications?
Yes, it can be. So the beauty of allergy shots is you can utilize it two ways. You can utilize it as a preventative, so it can actually prevent the development of asthma. So if you have a child who has nose allergies, who hasn't developed asthma yet, and you start immunotherapy, you can prevent the development of asthma.
So I've been told there's about an 18% chance that somebody will go on and get asthma if they've got an allergic nose.
Correct.
So we can prevent that.
Yes.
What about if they've already got it by the time you get to the doctor?
So if they already have asthma and you start immunotherapy, you can get the asthma under much better control. The term I use is we can make the asthma quiet. So we can calm it down so they'll have less symptoms, less reliance on medications, and then most importantly, prevent respiratory flare-ups or exacerbations.
Can you ever make it where somebody gets off medicines?
We can, yes.
That must be a joy to everybody also. Cuts down on the cost. So the allergy shots expensive or usually covered by insurance?
They're typically covered by insurance, and they're in the long run, they're the most cost-effective option we have.
Yeah, and has that been shown on studies?
Yes, yes, yes.
Yeah, so there was a great study down in Florida that says they're cost-effective. So don't avoid taking the allergy shots because of expense, or you're worried that they hurt. Do they hurt?
They don't hurt. It's a little poke, baby poke.
So what else is available on the treatment?
Yeah, so some of the newest options we have are a type of medicine called biologics.
Biologics,
Yes. So what they are, they're protein. They've designed to be proteins that block chemicals that can generate asthma. And so the goal of these biologics is to prevent exacerbations or flare-ups to the point where, so if kids are having bad flare-ups and they have to go to the hospital, if you use a biologic, it'll prevent the need for hospitalization.
Do you find that effective?
It is effective.
Yeah. In adult asthma, it's really changed the world. In pediatric asthma, you got to wait till they get so old and meet a requirement.
Correct. The indication's for 6 and above, and so we don't use a whole lot of biologics in kids, but there are a subset of kids that could use it, and so it's certainly a great option to have for the kids that aren't well controlled.
So with avoiding your triggers, taking relievers, taking the preventative medicine, what are your goals in the treatment?
Yeah, the goal of treatment is, we use one word: control. We want to get their symptoms under control so they can live a normal lifestyle, they can do normal activities, they don't have to be limited with what they do. They can function normally, and you'd never know they have asthma.
Must be great to be able to take a child whose life is being changed by having asthma and make it where they can be more functional, happier, the family's happier, you can take trips, you can have a good time and enjoy yourself.
Yes, that's right.
Karthik, Krishnan, you're a great teacher. You really, really are. And you lay the information out to where people are not scared of a disease, but they pay attention to that disease and get hooked up with a hopefully board-certified allergist.
Yes, yes.
Thank you for coming to the Dr. Bob Show.
Thank you for having me.
Yeah. You know, medicines make us enjoy life, but we've got to remember the things that we talk about every time we do the Dr. Bob Show. Exercise. Exercise actually will strengthen the lungs, and if you work on exercise with your provider, with your doctor, you'll find out how much exercise you can do before it will actually trigger an asthma attack, and whether you need to use your preventative medicine before. Be sure that you're eating properly. You know, we need to eat less, be more active, have a good time, enjoy yourself. Get 7.5 hours of sleep. Children at a young age need more sleep than adults do, so they may need 8.5 hours. They may need 9 hours of sleep. And so be sure that your child is getting enough sleep so that they can be productive and can be happy and can do their best in school and their best to perform tasks. And most of all, what is it we like in the Dr. Bob Show? It's that laughter in your life. Does laughter help asthma? No doubt about it. Proper socialization, having friendship patterns where you can go out and you can play and you can have a good time and you can push each other and shove and have a good time would be a gentleman, you guys. Knowing that that's part of your way to stay healthy. So most of all, I think we like the socialization, but there's exercise, eating right, and 7.5 hours sleep also to make you healthy and happy.